Hi, this is Pranav with 573 Medicine, and today I'll be talking to you about the external anatomy of the heart. So to begin, the first layer of the heart that you're going to encounter with the external anatomy is the pericardial sac. It's divided into two layers. They're called the fibrous and the serous pericardium. You can see here, the fibrous layer is more external and the serous layer is more internal. And the functions of the pericardium are to fix the heart to the mediastinum for protection of the heart and lubrication of the heart. If you have something called pericarditis or inflammation of the pericardium, it causes a friction rub on physical exam, and that's due to the loss of lubrication of this layer. So next up is the heart in situ. We have the apex of the heart, which lies between the fourth and fifth ribs at the mid-clavicular line. It's the region of mitral valve auscultation, and that's because you can imagine that blood coming from the left atrium to the left ventricle through the mitral valve is going to be hitting the apex of the heart, or the equivalent area on the interior side of the ventricle. Next up is the atrioventricular and interventricular grooves. So right here we have the right atrioventricular groove containing the right coronary artery. We have the anterior interventricular groove right here containing the left anterior descending with the left coronary artery here. And then we have the posterior interventricular groove containing the posterior descending artery. And these grooves minimize the compression of the arteries within them, and they reduce friction against the pericardial sac. Moving on to the actual chambers of the heart, we have the right atrium. And to begin, we have the pectinate muscles over here, which are these thin, striated muscular structures. We have the crista terminalis, which is clinically significant because it contains the SA node, and it's right here on the superior aspect of the right atrium. We have the fossa ovalis, which is the closure of the foramen ovale, so an embryonic structure there, right over here. And then we have the opening of the coronary sinus down here, and that is the drainage of the coronary vasculature. So they all go straight back into the right atrium. And lastly, we have the tricuspid valve, which you can see here, along the more anterior part of the right atrium, draining into the right ventricle. So next we have the right ventricle. We see trabeculae carnae here, which are more thick and pronounced muscles of the right ventricle, especially compared to the right atrium. We have the conus arteriosus, which is the entrance to the pulmonic valve and the pulmonary trunk. We have the supraventricular crest, which is this crest-like region on the superior aspect of the right ventricle. We have the septomarginal trabeculae down here, which contains the conduction system to the anterior papillary muscle. So that's important because damage to this can cause tricuspid regurgitation or just palsy of that valve. Next up, we have the tricuspid valve. So we have chordae tendineae, again, bridging the gaps between the papillary muscles and the valve leaflets. So we have the papillary muscles as well down here. There are three of them. There's a septal papillary muscle, there's an inferior papillary muscle, and then the supero-posterior papillary muscle. And the reason that they appear to be four of these is that this is a bit of a fanning out of the tricuspid valve, so you can see that the inferior papillary muscle has been sectioned. You can also see the cusps of the tricuspid valve, and of course there are three of them. We have the inferior leaflet, anterior superior leaflet, and the septal leaflet of the tricuspid valve. Next up, we've got the left atrium. So in this picture, we have a good view of the interventricular septum, which is divided into the membranous and the muscular parts. The membranous part is more frequently ruptured and needs surgical closure, while the muscular part is less frequently ruptured, but it can close on its own and is less serious. We also can see the mitral or bicuspid valve that's been cut away here, but this would otherwise be the entrance to the left ventricle from the left atrium. And then we also have the left auricle, and that's clinically significant because this is where, or a very common location for thrombus formation in patients with AFib. And that's part of why patients with AFib are at higher risk for cerebrovascular accidents. Next up, we have the left ventricle. So we have a better view of the bicuspid valve here. We can see the two leaflets as well, which are the anterior and posterior cusps. We have the chordae tendineae of the left ventricle, which you can see are very muscular and very pronounced. We have the papillary muscles, which are down here, and you can see they're attached to the chordae tendineae, and they're attached to the bicuspid valve. We have the anterior and posterior papillary muscles. And lastly, we have the trabeculae carnae of the left ventricle, and you can see these trabeculae are very thick, very strong, and that's because the left ventricle is pushing against so much pressure. And lastly, we have the aortic valve. So the aortic valve has aortic sinuses, which are these openings in the valve, and it's just a widening of the aorta at the valve. We have the three cusps of the aortic valve, which are the left, non-adjacent, and right leaflets. They're also called the posterior and semilunar cusps. We have lunules of the valve, which are these little pouches. And they look a lot more like pouches in this picture because, again, this is a fanning out of the valve. So you can imagine the 3D structure of the valve leaflets itself. And then lastly, we have nodules, which are these little nubs on the external surface of the valve. And that is all. Thank you for your time.